different million, like over 7 mortality in Nigeria. In collaboration with other Asian in over 7 mortality in Nigeria. In collaboration with other Asian in childbirth. We have accredited about 270 facilities across the country. Again, not having money should not be the deciding factor between life and death while giving life. This program was also extended to newborns, and we have started piloting that in 7 hospitals in Kano, 1,000 newborns from extremely. There are women who in childbirth do not die, but they have some very terrible complications called obstetric fistula. They are the poster person of somebody who is stigmatized, ostracized. So we partnered with all the 22 hospitals in Nigeria that can offer fistula surgery, and this is provided free. About 4,000 so far have had surgeries repaired to repair fistulas and their lives restored. And for all, we take care of the condition they have. They are automatically enrolled in health insurance under the basic healthcare provision. Last one to touch on is part of this sustainability program, whereby a lot of people in Nigeria are suffering from tuberculosis, HIV/AIDS, malaria. A lot of them typically were funded by international organizations and donors and approved by Mr. President. We now need to redesign the program so that all these people can be brought under the cover of health insurance. And our target is that before the end of this year, the next 2 years, we aim to have and move beyond just access that is paid for, and that's where we must get to as a country. The third thing I want to talk about is the quality of care. Many of us, when we go to hospital, to understand with the current medical inflation, what is the true cost of services, and therefore what is the real and fair premium people should pay. And that led to a revision of our tariffs and our premiums. So what we pay out, we doubled capitation in 93% from provider. And in addition, we also launched initiatives. Nigeria is undergoing what you call not just a demographic transition, but we are also going through most of the diseases people suffered in now. Diarrhea, cholera, all those things. Or maternal conditions. But right now, if you go to many hospitals, because as people are getting older and living longer, we have these chronic diseases. Now, in the Western and the infectious diseases decline, and you see more of the chronic diseases. But that's not what we're countries. We're still grappling with malaria, with diabetes, heart disease. We started looking at chronic partnerships, women, other types with sickle cell disease. Needs of those who are enrolled, in NHIA progress. Where the average Nigerian, the one where serve as a strategic purchaser, institutions are the cradle of innovation. University of Science and Technology there ranked based on their more innovative universities and academic institutions have always been those places that speak truth to power and the rigor from it alone. And nation building and building the health system that we need. And
my mic is working.
Now, you went to women, Southwest Nigeria. Can we have the list? Emergencies. And many people suffering from cancers, government, and they do not place. And they are dying because of funds. So how can people in the informal under the NHI hospital? Yes. So what can be done?
Thank you very much, Ma. We have, okay, sorry, let's start.
Good morning, sir. I questions down. The first thing I want to ask every health service, tell you that probably just like one or two that I still want to ask that also manage health, also be available for non-government workers.
In terms of problems and so on and so forth, I think the problem should not be seen at the level of universities, tertiary institutions, taking the initiative. One of the who is already leading on our own side, a sort of an agreement, gentleman agreement before you go, and fully, please.
Thank you so much, sir. Professor Akintenwa.
Thank you very much. Must have followed to now NHIA and all of that. What other KPIs, what other metrics are used to measure success from the within the context of your intervention? Again, looking at those in rural areas, particularly the poorest of the poor. In the course of collecting your premium, how are you able to do it without putting more pressure on those that are already poor?
Thank you so much. HOD of Mass Communication.
I'm very happy listening to your lecture, which is very interesting. But I have this probably 60 or 65. Probably 60 or 65. And from observation with this particular age, and more so, what can we do about particular age? And more so, what can we do about this?
Good afternoon, sir. And private program. Also, health care centers saying that, okay, Osila is sustainability. Care centers saying that, okay, Osila is sustainability. One of the pillars is related to even our security when funds are not even.
Insightful lecture. I noticed similar packages for men. Patient visited public hospital. Similar packages for men. Patient visited public hospital, but the prescribed drugs are unavailable and must be purchased from a private pharmacy at a higher cost. What practical system can reduce this out-of-pocket financial burden? Thank you, sir.
Whenever anybody presents, you're always worried whether anybody's actually listening to what you're saying or not. So the evidence of these questions that you've asked, and a lot resonated and at least provoked a lot of questions. And I will do my best to that relates to people's experiences. I think on the question about is health insurance as to whether it's ever private hospitals. And so we do work with the private sector closely, and we do reimburse them, and people should have a choice of providers, so that if, whether by convenience or trust or whatever market rates observe, that the issue of waiting for codes, referral codes, delays care. So you go there, you're waiting for 3 hours. April 1st, 2025, we sent a second one. Please let you know, there's a protocol. This has been sent because delay can be fatal. And so, but not to leave it up to the end. 1 hour maximum, treat the person. So that has been, that 1 hour mandatory time frame has already been implemented to address some of those things. The question about non-discretion of the healthcare provider, but these are rights and these are entitlements and these are benefits that the enrollee must have. Well, thirdly, in the FCT, now that we've piloted, but also in many of our states, in volume hospitals, so that we don't want to wait for in the hospitals, so that we don't want to wait for in the health systems and effectiveness health systems and effectiveness of the system. Only men of the system. Only men. Package, and that's gender agnostic. Things that affect them that gender agnostic. Things that affect them that NHI move from NHI. Nigerians can enroll. Nigeria has a state health insurance, and the state health insurance, and there are at least in the country, etc. And our plans are there and they're available for all the indicators. Revamping of the indicators. Revamping of the emergency medical transportation system, NEMSAS. Looking at the national broad transport system. So there are lots of interventions. Is that period of an emergency where even if you've had good quality antenatal care, anything addressed. So what we're doing is address, but some maternal mortality rates. So what we're doing is address, but some maternal mortality rates. You will have access to free surgery. You will have access to free surgery or whatever is needed to ensure that person gets better. Now, these are interventions. Once you've sorted that out in the program, we are, and no exclusions, whether it's public or private, World Health Organization, from other nations, and let the determinants institutions. So please feel like integrity and of trying to speak and empower. Most people judge insurance works on the sustainable. Most people judge insurance works on the sustainable. That means that than the poor. 5% of poor. 5% of the social mandate based on the numbers. We look at how the social mandate based on the numbers. We look at how this living standard survey. We want to know how much out of pocket, because that has not reduced your pay. We want to know how much out of pocket, because that has not reduced your, not even just in the number and the individual. We're seeing people complete treatment. So there are multiple indicators that we track externally, but also internally, other indicators. You look at a population, formal sector, there are those who are in the informal sector. They can pay, but they wait until they get sick to go and pay. And therefore, they are exposed to a lot of these problems we're talking about. That's the informal sector we need to educate. Then there are those who are poor and vulnerable and absolutely do not have anything to pay. That's the group that was targeted by the Basic Healthcare Provision Fund. The government pays their premiums. That you're asking them to pay on an annual basis. That's why that's there. And right now, we heard recently, if you have been following the news, the House of Assembly recently has moved and passed for the amendment of the act to go from 1% to 2 people. And states are also encouraged to have state equity funds. So the poorest, the government, and others have to support even the premium contribution they are making. I think for the most part, I'm not sure if I have left out any other question. Was there anyone? Sorry? Yes, there are many hospitals in the Southwest. I can even tell you categorically, even in Lagos and Ogun, almost all the general hospitals have gone through accredited for these programs. There are also those accredited for insurance broadly, but those that are accredited for these programs that have obstetricians there in the list. And my team is here, they can provide you with those information. Thank you very much.
Thank you so much, sir. We have listened to the lecture delivered by Dr. Kelechi Ohiri.
And I know that we should take full advantage of it. Professor Akinterewa raised a very important point which the DG has not, who you can work upon. Secondly, you mentioned about 1 hour as your circular of April 2004. Even 1 hour, sir. Even if that's what we are going to take away, the nation will take away from this lecture, it should be reduced. when somebody is sick, waiting for 1 hour before it's attended to. Depending on the type of sickness, he might even die. Extend it beyond 1 hour. They should attend to patients and follow up later. Let us abolish this waiting period. Somebody that's confirmed to be a registered member under this scheme should be attended to without waiting. So please attend to Professor Quintero.
So, well, this is becoming like the House of Commons. The 1 hour was put as a maximum, and this was done in consultation with Association of General Medical Practitioners, the HMOs, everybody was there. I don't believe we should wait till 1 hour. Immediately they show up. If there are referrals and let's say they want to see a consultant, etc., people typically used to wait 3 hours, 4 hours, some the whole day, and it was used as an excuse. And of course, we can say 30 seconds or 30 minutes or whatever. But what we're saying is that as a first step, we don't want to hear that somebody spends up to an hour waiting. That doesn't mean we should solve for the lowest common denominator, which is 1 hour. We still want them to address it ASAP immediately. But what we were trying to do was say, even if you don't hear from them, if your mark at the latest, what we do on this and enforce compliance, then we can always reduce it of trying to improve a collaboration. How about I throw it back to your good selves? Propose how we can collaborate. And then we can, with HIA, have signed an MOU to collaborate. This is
Aremu, for the closing remarks. Aremu, for the closing remarks.
Yes, thank you so much. It's a closing remark, but let me thank you so much. It's a closing remark, but let me tell that. Thank you so much for giving us this opportunity. A few days ago, Professor Olabisi Oduwole had some discussions. Professor Olabisi Oduwole had some discussions with me as regards logistics for this lecture. So I want to thank you so much for not taking a dime from the university on your flight. Please, let's put our hands together for him. The DG did it from his own. Thank you so much. Thank you so much. Thank you so much. It's also our tradition to say, okay, take before you go, I need to fuel your vehicle. Then the G also said, with all this, no matter what, the African culture is to say thank you. You want to appreciate in your office, you will always remember to make. You want to appreciate in your office, you will always remember to make a presentation on the platform. So please come and do that. Yeah.
Sorry, it's the VC that does this all the time. So I would have practiced. So, Dr. Ohiri, this says Award of Excellence presented to Dr. Kelechi Ohiri in Reimagining Health Financing in Nigeria from Access to Financial Protection from the Faculty of Medical Laboratory Science, Achievers.
Token of appreciation to you. So I have his authority. Madam will find 1 or 2 things useful there. Thank you so much. Yeah. God bless you, sir. I must also appreciate members of the entourage of the DG. Thank you so much. Thank you so much. Thank you so much, and God bless you.
I invite the chairperson, local organizing committee for this program, Dr. Oluwayemisi Ode.
Thank you, madam. Just been told that the zonal coordinator is around from Ibadan. Sir, is it the one that stepped out? Oh, okay, sir, please come up. That's the zonal coordinator.
I appreciate our visionary Pro-Chancellor, Professor Bode Ayorinde, our highly esteemed, highly acting Vice-Chancellor, Professor Oyesoji Aremu, for their support and encouragement in making today's faculty lecture a success. Thank you very much. We also appreciate the Registrar, Bossa, the University Librarian, for Dr. Kelechi Ohiri. We say thank you for coming to give us insights on the topic, Reimagining health financing in Nigeria from our destination. I won't forget to mention the members of your entourage for coming, and God bless them as the deans, directors, head of departments, professors here present, unit coordinators for honoring our invitation. To the works department, ICT department, mass communication department, to all that joined virtually, I discovered that about 5 people joined online. We say a big thank you. I won't forget to appreciate thank you very much. And also members of my committee for the teamwork. Finally, I thank God Almighty. Please.
I'd like to invite members of the members. Let me say thank you so much and God bless you. Thank you.
We'll be having